Okay, let's talk about chest pain. This is one of those topics that, it makes even experienced doctors take a deep breath. Why? Because it's probably one of the highest stakes situations you're ever going to face, both in the clinic and definitely on your exams. So what we're going to do here is a super fast, rapid-fire revision. We're going to break down the absolute must-knows so you can stay cool under pressure and nail these questions every single time.
So, a patient walks in with chest pain. What's the very first thing you do? Seriously, this is probably the most important question. And the answer isn't figure out what's wrong. Nope. Your first job is triage. You have to, without a doubt, rule out the stuff that can kill them, like right now. Everything else is secondary.
All right, so here's our game plan. We're going to tackle this just like you would in a real emergency department. First up, the chest painkillers, the big bad stuff. Then, we'll look at some cardiac red herrings, things that seem like a heart attack but aren't. We'll jump over to the lungs, then talk about the great imposters. And we'll wrap it all up with 5 clues to clinch it. Let's get started. Okay, Section 1, the chest pain killers. Remember, always think life-threatening first. This is your mental checklist for anyone, and I mean anyone who comes in with chest pain. It's your first line of defense.
The classic. Doc, it feels like an elephant is sitting on my chest. You're going to hear this, or something like it, a lot. And when you do, your brain should immediately scream one specific diagnosis. And that, of course, is a myocardial infarction, a heart attack. We're talking about that classic, crushing pain right in the center of the chest. It often radiates right down the left arm, up into the jaw. You'll also see other signs that something is seriously wrong, like sweating, nausea. But the ultimate proof, that's in the blood work. You're looking for an elevated troponin. That's the signal that heart muscle is actually dying.
Okay, now listen to this description. It's totally different. The patient isn't saying crushing. They're using words like ripping or tearing. And the key part, they say it goes straight through to their back. That specific language is a huge clue for something else entirely. This right here screams aortic dissection. This is a flat-out emergency. We're talking about a tear in the inner lining of the aorta, the biggest artery in your body. It's catastrophic. And there's one physical exam finding that is an absolute classic. You have to know it for your exams. And here it is. You absolutely have to check the blood pressure in both arms. Why? Well, think about it. That tear, that dissection flap, can block off blood flow down one arm's main artery. What does that do? It creates a big difference in the blood pressure readings between the two arms. If you see a difference of more than 20 points, that is a massive red flag. Do not skip this step.
Okay, our third killer is one you might not see as often, but it is just as deadly. It's called Boerhaave syndrome. And what is it? It's a complete, full-thickness tear of the esophagus. It's a total disaster because all that nasty stomach acid and food starts leaking right into the chest.
So, how on earth do you spot this one? Well, the history is the giveaway. It almost always happens after a really bad bout of forceful vomiting or retching. Then, when you examine the patient, you might feel something weird in their chest or neck. Subcutaneous emphysema. That's air that's escaped under the skin. It literally feels like Rice Krispies or bubble wrap crackling under your fingers. It's a very specific and very scary sign. All right, moving on to Section 2, cardiac red herrings. Now, these conditions are coming from the heart, and yeah, they can definitely feel like a heart attack. But they're different, and you need to know how they're different. So, first up, let's talk about angina. All angina is chest pain because the heart isn't getting enough oxygen for what it's being asked to do. Now, there are 2 flavors. Stable angina is predictable. You walk up a flight of stairs, you get chest pain. You sit down, it goes away. Unstable angina is scarier because it happens even when you're just sitting there at rest. But here's the absolute key to telling it apart from a full-blown MI. With angina, no heart muscle is dying. So what does that mean for your labs? Your troponins will be normal.
Next up, pericarditis. This is when the sac around the heart gets inflamed. The pain is usually sharp, and it often hurts more when you take a deep breath in. We call that pleuritic. But the absolute money-in-the-bank, high-yield clue is that it's positional. So you ask the patient one simple question, does it feel any better if you lean forward? If they say yes, you've got to be thinking pericarditis.
Okay, so we've talked a lot about the heart, but let's not forget, the lungs live in the chest too, and boy, can they cause some serious pain. So let's look at when the lungs are the culprit. Here's another one you just can't afford to miss,
the pulmonary embolism, or PE. The classic story for your exams is always going to be something like this. A patient who hasn't been moving around much. Maybe they just had surgery, or they were on a long 12-hour flight. All of a sudden, they get super short of breath and have sharp chest pain. Those risk factors for blood clots should make a big alarm bell go off in your head for PE.
All right, next up is a pneumothorax, a collapsed lung. And let me tell you, exam writers love the classic stereotype for this one. They'll tell you about a tall, thin, young guy who, out of nowhere, gets a sudden, sharp pain on one side of his chest. The key physical exam finding? You grab your stethoscope, you listen to their chest, and on that one side, you hear nothing, or at least way less air movement. That's a huge clue.
Now for our last group of diagnoses, the great imposters. These are super common, and they are notorious for making patients think they're having a massive heart attack. It's your job to unmask them.
First up is GERD, or good old-fashioned acid reflux. And man, this one is a biggie. The patient will usually describe the pain as burning, but the real clues are in the timing. You have to ask, when does this happen? Is it after you eat a big meal? Is it worse when you lie down flat at night? And the final test, if a little bit of antacid helps, that points you right at the stomach, not the heart.
And our other great imposter is costochondritis. This sounds complicated, but it's just inflammation of the cartilage where your ribs meet your breastbone. The key to figuring this one out is that it's a touchable pain.
I mean this literally. The diagnostic tool is your finger. If you can poke around on their chest wall and find the exact spot that hurts, and the patient goes, "Yep, that's it, that's the pain," well, you've just reproduced it. That's a huge sign that this is a musculoskeletal problem. It's coming from the chest wall, not from the heart inside it.
Okay, that was a lot of information, I know. So let's boil this whole thing down into 5 simple rules. Think of this as your cheat sheet, your exam gold. These are the clues that will let you clinch the diagnosis fast.
Let's go through these one by one. Rule number 1. If you see chest pain plus sweating, you treat it like a heart attack until you can prove it's not. Period. Rule 2. If the pain is sharp and hurts when they breathe in, that's pleuritic pain. Your brain should immediately go to the lungs. Think PE or a collapsed lung. Rule 3. Is the pain positional? Better leaning forward, worse lying down? That's the classic for pericarditis. Rule 4. Can you poke it and it hurts? Is it tender and reproducible? That's musculoskeletal. That's costochondritis. And finally, Rule 5. That tearing pain that goes to the back, that has to make you think aortic dissection. These 5 patterns will get you so far. Burn them into your brain.
So look, you know the clues now. But knowledge is one thing. How do you actually stay calm when the clock is ticking down on an exam, or you have a real person in front of you who's scared? The answer is having a system. It's not about being the smartest person in the room, it's about being the most systematic. Always, always, always start with the killers first, and then work your way down. That framework, that mental scaffolding, is what will keep you calm and let you do the right thing when it matters most.